Before you start, just a couple of words. Thank you, Dr. Inga. As you've noticed, the morning first part of the session was devoted to interventional cardiology, which is not something which is, very close to everyone. At least for the second part, this second session will be devoted to what I would say more of medical cardiology, but not just cardiology, it's cardiology, internal medicine, nephrology, and many other issues, which is, I would say, the bread and butter of all doctors. Cardiologists, internists, nephrologists, pediatricians, etc. So today, Dr. Mahesh, Krishna Kumar Mahesh, will present a topic which normally we tend not to think about, but which is present in most of our patients, diabetic patients with chronic heart problems and secondary or primary kidney problems. At the end of the day, these two systems, they become so closely interrelated that treating one without considering the other system doesn't really work. So today, Dr. Mahesh will present to us what is called the cardiorenal syndrome as a syndrome. What is it exactly? How we decided to put the cardiorenal syndrome separately, the different types, the modalities of diagnosis, and most importantly, management. So please, Dr. Mahesh, thank you very much.
Thank you so much for the kind introduction, sir, and thanks for the invitation for the speech. Like I said, most of the time we are talking about interventions, and so yes, intervention is a good aspect of cardiology, but I think medical management, these days we see a lot of things we can do with medications, and most of our patients do have an underlying renal problem. And like Dr. Ramjatan completely correctly said, we tend to just ignore it. The creatinine is just one of those things we look at and decide, okay, all right, it's not too bad, if it's not too good. But the interrelation between these two organs is phenomenal. Like I was just reading about this about a few months back, and the one thing is, as soon as a kidney problem starts, most of these guys get excluded from clinical trials. And most of our patients, at least 50% of them, do have a renal problem, and you keep wondering, how do you treat them? Because none of these have any evidence base. And heart has a very intense relation with all organs, as we said. But with kidney, I think it's just marriage, because 25% of the cardiac output goes to the kidneys, and interrelation is very important, because kidneys make sure that the blood volume is kept in the right conditions, the electrolytes are in the right, and the heart needs that. Even a little bit of extra fluid and the heart suffers. And similarly, the kidney needs this output. It needs that 25% of the cardiac output for it to be able to do these things. And just like any marriage, as soon as there is a problem here, it starts off in a downward spiral, hurting both the organs. So this is what cardiorenal syndrome is about, meaning one organ gets into trouble, and it's got a manifestation on the other organ, and it just keeps going down in that track. So I'm just starting off by kind of usual patient we all see. Like this is a 74-year-old lady who's been following up with this. Just for diabetes, she never had any heart problems, so I used to see her with my colleagues outpatient lots of times. So one night she comes in with an acute LVF. The ECG shows some ST depression in the precordial lead, so diagnosis is not so difficult. Bad lungs, really desaturating. She needed NIV overnight. By morning, with our usual standard treatment for acute heart failure, NIV, Lasix, she picked up very well, and I was so happy about it. Even the numbers we usually look at, just hemoglobin is good, creatinine 132, kind of borderline-ish. Echo, not a very dilated LV, so definitely that gives us that she's not one of those persons who's really, the heart function is really deteriorated. She has wall-motion abnormalities in a couple of territories, and so this is a classical ischemic LVF, and she's responded well to treatment. So I was bold enough to say, okay, ischemic LVF, we need to do an angio, and we went ahead and did an angiogram. LAD was totally occluded, subtotally occluded, little like what Dr. Yaru had showed, circumflex, but a very complex proximal lesion with an obtuse marginal. And I remember discussing with Dr. Duma what he would do in this case. And we both felt like we would go for, bypass as an option in this patient, diabetic, bad vessels, long lesions. But that's not the topic. So the creatinine at the time of admission was 132. And the next day, as usual, even though I don't want to look at it, our colleagues in the ICU, they rigorously follow creatinine and hemoglobin every single day, whatever you tell them. So creatinine has gone up to 166. And now this is an acute kidney injury, AKI. This is standard, meaning whenever the creatinine is going up above 26, within 48 hours, the diagnosis is you have an acute kidney injury. And the other features of an acute kidney injury is an urine output coming down within 6 hours or a creatinine. And if you look carefully, most of our patients tend to have this. Maybe not most, but at least less than 50%, around 50% of our patients do have this happening after a procedure, after an ICU admission. So cardiorenal syndrome, like we just said, is a spectrum of disorders involving both the heart and the kidneys, in which an acute or chronic dysfunction in one organ induces an acute or chronic dysfunction in another organ. So to be able to, it's such a broad thing. So to try to, kind of put it into perspectives to help us manage better, to see the hemodynamics, what's going on. So we have classified it into 5 groups. So type 1 is a situation in which there is an abrupt worsening of a cardiac condition leading to an acute kidney injury, most of the things which we see. And type 2 is a person who is having a chronic heart condition, like something ischemic cardiomyopathy overtone, developing a kidney dysfunction. Type 3 is a very interesting thing, and it's something I think, frankly, I never really realized it till about a year back, and we started seeing patients who have an acute kidney injury, and just a few days later they're going to profound heart failure. Like I remember this gentleman who had some chemotherapeutic agent and went into an acute kidney injury, and in 3 days' time he was in florid LVF. So the heart function, the troponin was normal, the LV function was normal, ECG. So it is a typical type 3 cardiorenal, meaning an acute kidney injury which is now insulting the heart. And type 4 is the thing which we all see, patients with a long-standing kidney problem in which the heart is being affected, which we will be, we cannot discuss all the 4, so we'll try and concentrate on the ones we see very predominantly, that's the type 1 and the type 4. So type 1 is an acute kidney injury. So you have an increase in creatinine and we have reduced urine output, and it lasts less than 7 days. But bear in mind, there is not always injury. Sometimes this worsening of creatinine and reduced urine output is just because there is not enough, there's a transient decrease in the volume. There is not enough blood going into the kidney system, and that causes the creatinine and the urine to be affected. And also drugs which can act on the renin-angiotensin system can also cause this. You don't really need to have a kidney injured. So you have any drugs which is affecting the renin-angiotensin system, or you have blood volume reduction, you can have parameters of creatinine going up and urine output coming. And the usual types of CRS we see is an acute heart failure, an acute coronary syndrome, and cardiac surgery. I think cardiac surgery is, by far really very common, and we see that. So why does it happen? So it's again an interesting thing. I used to wonder, like this lady patient, she never had hypertension. Her lowest blood pressure might have gone down as 110, surely. So, but she still went into an acute kidney injury. So there are 2 aspects of it. One is the cardiomomentum syndrome, we call it, meaning the heart is not able to pump enough blood, so there is not enough GFR, so there is renin-angiotensin aldosterone activation, sympathetic activation, there is hypoperfusion and causing it. But most of our patients, like you would know, they don't really develop that much of hypertension to do that. So why? So it's because of venous congestion. Like whenever you have a heart failure, what happens is the filling pressure starts going up. You would have seen that. The left ventricular diastolic pressure from 8 or 10 or 12 goes into 20, 25. And that is impeding the renal veins. Now the renal veins are congested. So how do the kidneys work? They need to have a hydrostatic pressure. They need to have a high arterial pressure and low venous pressure. So that's how all the filtration happens. So, but imagine if the venous pressure is going up, that force of filtering comes down. So most of the time an acute kidney injury in a heart failure is because of venous congestion. So unless we control the venous congestion, these patients are not going to get better. It's not a problem with the heart's forward pumping. The blood pressure is most of the time, just think of all the patients you had. Most of the time you have good blood pressure, or fairly good blood pressure, and you can always correct it. But still they are in AKI because of the venous congestion. Meaning the gradient between the artery and vein is lost, so the kidney can't filter anymore. So, and what are the parameters we use? We always use this traditional parameters of urine output and creatinine. Urine output is very low specificity because you can have low urine output for many reasons. The person is not drinking, he's had perspired too much, lost a lot of fluid, but it's very specific. So if you have a reduced urine output after a procedure or a patient coming into the ICU, that's not a good sign. But it might not always be an acute injury. And the next thing is, of course, is the creatinine, which we use, and we think creatinine is completely related to kidney dysfunction. But the thing you have to understand is creatinine is a surrogate marker, meaning it's something that our muscles, when they metabolize, they make it as a side product, and this is excreted by the kidney, and we use creatinine because creatinine is not absorbed back in. So lots of times we also use urea to find out if there is renal failure. But urea goes up very, very high, and we always say it is pre-renal acidemia. That's because the urea gets reabsorbed. Creatinine doesn't get reabsorbed. So creatinine comes because of muscle metabolism and it's excreted. So your kidney is now damaged, but the creatinine will start going up. The level of creatinine in the system has to keep going up and up and up. Then only the creatinine starts rising. You get that point? Because it is not something the kidney makes or something. It is because the system has to reach a stage of high levels of creatinine to reflect it. So lots of times we are delayed in picking up an AKI. And this patient is typical example. Like she came in, after 48 hours only we saw the creatinine going up. It's because the body has to make a lot of creatinine and the kidney is not able to secrete it, then only it starts signs of going up. And another interesting thing is, another thing which we see with our patients is, they come in to us with a creatinine of 1.4. Okay, we don't worry about it too much. And the next day they come with, in 1 week time they come back something else and it's 2.2. And you wonder, why did it jump up so much? That's again the problem, because the creatinine will go up to 1.3 only when 50% of the kidney is gone. So it's not a very sensitive sign of it. So of course we are getting all these new AKI markers which tells you, just like our troponin, which the kidney is being affected. But for the time being we are depending upon urine and creatinine. They are good markers, but they are only giving idea of the functionality of the kidney, nothing about really whether the kidney is injured or not. Of course, there is this granular and epithelial cast. We see, I think the skills for looking at these things are getting lower and lower. When we were training back in the 1980s, our professors were so wanting to look at the urine all the time, and they could look at these casts. I don't think I've ever seen a cast other than in textbooks. All right, so this is a slide which is just explaining to you what I was just mentioning about kidney failure. Meaning, a normal kidney, then we have an injury to the kidney, then there is damage and the kidney is necrosed and it's destroyed, then only you have the creatinine and the urea and the urine output going in. See, it's such a delay, so you're picking up it much, much later. It's like having a patient with an acute MI coming in and you're diagnosing it only when completely the myocardium is destroyed. How bad can that be? So we are having a lot of these injury molecules which are now coming up, which are able to identify the problem much earlier. We haven't, kind of been able to find out which is the best one, because when you had these injury molecules, initially we had the creatine kinase for the heart, then we had the CKMB, then the troponin, now we have high sensitive. So, work is going on to try to find out which is probably the best marker. But still, I don't think we have that yet, but that's definitely going to be the way to go for, to find it out. So, if I can just take a little bit of time here. So the injury molecules can be, right. So the injury molecules can be, there are 3 types of it. So the unifying concept of heart and kidney problem is fibrosis. Right. So that is the unifying concept of why the heart and the kidney gets affected all the time. So you are looking at markers of fibrosis. So galactine. So this is the guy who starts off the whole process. Suppose you can measure the galactine and say, oh my God, my galactine is high. Then you already understand, I have a patient in front of me, or I am at high risk for heart and kidney dysfunction. But since when the kidney is already damaged, then you have to look at these markers. For the glomerulus, we use the cystatin. And for the tubules, we use NGAL, KIM, and these are. NGL is a neutrophil galactinose associated lipocalin. It produces by the tubular epithelial cells, and these tubular epithelial cells, when they are damaged, you produce a lot of NGAL, and you can measure it in the urine. So that's a good kind of marker to find out whether the kidney is under injury or not, but not very specific. The other two are very interesting ones which are coming up. Basically what they do is when the kidney is injured, what it does is it stops mitosis. It just says, okay, I'm not going to grow anymore, my epithelial cells, I'm going to hold it here because I'm under injury. So when that happens, when the epithelial cells are not going through their normal process of development, not mitosis, not developing, these guys come out. So these are much more sensitive markers of kidney injury. And I'm sure 5 years, 6 years down the line, these are going to be coming out, and we are able to pick up our kidney failure patients much earlier and maybe offer treatment. And these are things which happen much later. This is again a very interesting thing, because when the kidney is not working, all right, how do our urea goes through the kidney? So when there is a lot of metabolic products being made in the body and the kidney is not working, the body is trying to somehow excrete it. What it does is it produces lots of urea goes out through the intestines now, because it has to push it out. But when there is a lot of urea going into the intestines, it changes the microbiota in the intestine from a normal kind of bacteria to another kind. And these guys, what they do is they produce a lot of inflammation. And one of the things which you can measure is this. So when you have high levels of these things, you already know your kidney is really gone, because the urea has filtered into the intestine, which shouldn't be there, and it's made a kind of different bacteria there, and they are producing these inflammatory markers. So very interesting things which are happening in the field of nephrology. Right, so we're just going to go forward at the treatment of heart failure. The treatment of heart failure, I think, acute heart failure, we all know it's just decongestive therapy is the most important thing, of then ACE inhibitors and beta blockers. We'll try and mention a few things about it. So loop diuretics is the mainstay of treatment, for sure. If you have a patient with heart failure, whatever type is, like I was explaining to you, most of the time it is a venous congestion, and if you don't reduce the congestion, the kidney is not going to get better. So we all use diuretics, and they are working through they get excrete, they don't come through the glomerular filtrate. Very interesting thing. So when your GFR goes down too low, meaning your your perfusion is too low, that's why we have to act very quickly. Just like when a patient with an acute MI comes in, we want to give them the antiplatelets and revascularize quickly. Same thing with the kidney. If you do not protect them at that stage, where you give your chance for the diuretics to work, you had it. Because they don't come through the GFR, they come through these tubules, proximal tubules. So we should get some sort of renal perfusion there for them to work. And once they start, urine starts coming. So, how do we, lots of things, I understand is how much diuretics do you use? So we have some sort of models to go forward now, because there are some formulas which tells us how much to give, what type to give. So a patient comes in, we can use intravenous. So standard thing is, if the blood pressure is low, you give infusion. If you do not have low blood pressure, you can give boluses, but you have to give pretty good doses of it. So if you're having good amount of urine output, you continue with the same thing. And how do you decide whether you have good amount of urine output? You have to have a sport protein of more than 50 to 70, and urine output in 6 hours should be 100 to 150 ml per hour. So this is kind of basic thing you have to ensure. Otherwise, remember that congestion is not going to go down. If the congestion is not going to go down, nothing is going to get better. So if you feel that it's not working, what do? Of course, we increase double the dose. The next thing we can do is add another guy around it, because we are trying to block the nephron at another level now. So I have fantastic response whenever I use a thiazide diuretic. Most of the time I can't use an aldactone, my potassium is going up. But you find that you're using so much of Lasix, but still no urine output. It's amazing. You just give 25 milligram of hydrochlorothiazide or anything, and the urine just is. Yesterday night also we had the same situation. Patients come, no urine is less, you give Lasix infusion, you give a diclor, he's passed 4 liters overnight. So just add another diuretic to act on another segment. I don't think I have time to explain how that works, but it works. And if it's still not working, the patient is getting sick, we have to go for inotropes. This is not one of our favorites we use, but it is important to try to make sure the kidney keeps excreting. Otherwise, you're going down this channel, and you need all these sort of things. So Lasix, any of them can be tried, but I think Lasix is the one which has all the evidence. And we increase the dose. If it's not working, you add another one to the different aspect of the nephron loop. And these are the criteria you have to meet. So our patient now on day 3, like I said, I don't want to look, but my colleagues in the ICU definitely want to look. So the creatinine is now 210 and the urea is really 132. But urine is coming, she's looking good. So what do? Do I stop my Lasix? Do I stop all my drugs because my kidneys? No, that's what generally we do. Like when we see the creatinine is going up, we want to go back. We don't want to give any more Lasix. We think Lasix is injuring the kidney. So this is an interesting study which was published many years back. A lot of us would be aware of it. So if there is no renal failure and there is renal, even without renal failure, the outlook is not so great after a year. But in this situation, even if you have worsening renal failure, but there is diuresis, it is much better than worsening renal failure and no diuresis. So we should not worry that the creatinine is going up as long as the patient is getting better and diuresing. That is so much better than this one, because if you are having worsening renal failure and no diuresing, meaning if you take off your foot off the Lasix, we have problems. So it's the same concept you are seeing here. So there is some pseudo-EK and pseudo-worsening, meaning the creatinine and urea, creatinine and urine, like I said, is not indicative of kidney injury. They're just saying the function of the kidney is affected. So if your patient is improving, if you are making enough urine, even if your creatinine is going up, just be bold and carry on. So this is just the same thing that I was highlighting, that the loop diuretics are not per se nephrotoxic to the kidney. They help, but you have to understand if we are depleting the system too much and the patient's glomerulus become hypertensive, you can injure. But that is something we have to be very careful about. So pseudo-worsening kidney failure is a situation in which the patient improves, the creatinine increases. So So as long as even though your creatinine is going up, if the patient is getting better, I think we should just continue with the standard treatment we are doing. I think in future when we have these newer molecules which indicates kidney marker injuries, maybe it will be helpful to diagnose it. So another interesting thing which I thought I should bring up here is, a lot of people would say it's probably because of my contrast that I used that the patient went into renal failure. So this is something which I again was searching for. Lots of times we are very scared to use contrast. Why? Because I think all these studies which are done on contrast causing renal injury are because of the company it keeps. Where do we use an angiogram? Most of the time is a patient like this. Patient has come with a heart failure or acute MI, low blood pressure. You need to do an angiogram to protect the heart. So use contrast. But that is a very different patient from a person who's got a creatinine of 3, very stable, and it's coming to us with a stable angina or something like that. So it depends on the company it keeps. So if you have a sick patient, hypertensive, a lot of things going on, you use contrast, there is a high degree of a chance of kidney injury. See, even the terminology now they have changed. So initially, many years back, they used to call it contrast-induced nephropathy. Now they've just changed it around. They have made it contrast-associated acute kidney injury, meaning it's just not the contrast which is doing it, it's the whole milieu which is causing the damage. So we should be mindful of that and not stay away from giving contrast to patients who are stable. And these are backed up by big studies now which have shown that chances of worsening is low. So this is a study which for brevity of time I have not put the slides up, but there is hardly any difference. And this is another number, 1.2% of the patients had a post-operative increase in plasma creatinine level, that was 50% above baseline, and none had more than 100% or required dialysis. Right? But there are of course a lot of confounding variables in this. This is a trial which is done on stable patients. It's not done in somebody who's coming with an acute MI or in cardiac shock. But we have to be careful. I think we have to be bold in using contrast, but it depends on the type of patient we are using. So how do we protect it? So of course a lot of guidelines which tells us to use these things, but these are really not based on lot of randomized controlled trials. But I would feel very secure if I was using this. So you give 12 hours before and 12 or 24 hours after saline. And there is no evidence that acetylcysteine or bicarb work. And how much would I use? I think kind of good formula is to less than use double the patient's basal GFR. So if you have a GFR of 30, try to do your angio, whatever it is, in 60 ml. But I have tried to use this, and I am finding it that it really doesn't do much harm. But of course, the patient has to understand. But I haven't had any situations in which these patients had to go for renal dialysis or any of those things. So this is just the thing. This is actually picked up from NEJ. So this is what they recommend. If you try to stratify your patients, a low risk, just use low osmolality and consider suspending nephrotoxic medication. And if it's high risk, same formula, but you hydrate them. So this is something I just wrote it down to show a patient with an acute heart failure. So if the patient is like our patient, good urine output, she's feeling better, oxygen coming out, keep diuresing, don't worry about your urea creatinine. As long as patient's feeling better, that's good, that's good. So, but suppose you feel that urine output is not going down, you're not so sure whether the volume is coming down, urea and creatinine is going up. So now we need to look at them a little more carefully. Is it, I'm not using enough diuretic, is it something else? What's happening here? She's not diuresing, creatinine is going up, patient is the same. I think, a lot of things we can do is we can use what we call as a POCUS, meaning point of care ultrasound. Point of care ultrasounds are really useful to detect these patients. You look at the IVC, you look at the hepatic veins, most patients you can be seen it very clearly. And you find that there is a problem, it is fully congested. Again, we have to aggressively try to decongest them. But if you feel that the congestion is less, we are looking at another completely different patient, and this is a patient who's probably gone to a real acute kidney injury, kidneys are damaged, and our pushing on with diuretics and other things will not work. So the take-home message I wanted to say was, patients doing well and diuresing, keep going. But if the patient's not diuresing and we are not happy about fluid or still considering this, then an ultrasound really helps. And if you do not have an ultrasound and an X-ray also, I found it very useful, because you see that you do an X-ray and you see still a lot of pulmonary plethora. We need to somehow diurese more aggressively. So this is just what we can look at. Honestly, I've never done these things, but these two are very easy to do, and most patients it can be done. So would you give RAS inhibitors in a patient with an acute kidney injury? Yes, they all say AC inhibitors are fantastic for kidneys, but if you look at, none of the clinical studies are done in acute heart failure. It makes sense to use it because they reduce the hyperfiltration of the kidneys. Would I use it if a patient is AC, ARB, naive, meaning it's not been used in them? I would not use it. But a lot of our patients are already on it. What do you do? So these are not, again, not on any randomized control trials. These are just what the recommendations are in ESC and others. So if your creatinine is above 2.5, don't do anything. Don't start it. But lots of times I said our patients are already on it. Then you keep going. But if your creatinine is going up above 3 or worsened by 50%, reduce the dose by 50%. But if creatinine goes above 3.5 or 100%, just stop. Don't try it. And beta blockers. Beta blockers, I think most of us are aware of the fact that you do not try it in an acute heart failure, because these patients are exquisitely dependent on that stroke volume. So when you have cardiac output, you have stroke volume and heart rate. So stroke volume is kind of fixed in most of these patients. They're just getting time to adapt to the ejection fraction has now come from 60 to 35%. It's going to take some time for the heart to dilate. So it's going to get your cardiac output. So immediately you have to understand 60 to 35, that stroke volume has come down significantly. Now it is dependent on that heart rate to get the cardiac output. So if you go and block that cardiac heart rate, you're going to have a very sick patient. So we do not try it in an acute heart failure situation, but once the patient is stabilized, the cardiac LV is more adapting to the situation, we should use it and we should titrate it. So yes, there are no, specific therapies for it. Early identification and treatment is the thing. Make sure the volume status and hemodynamics are controlled strictly and avoid nephrotoxic agents. And I'm sure we're going to get biomarkers coming down in the next 4 or 5 years, which will help us to stratify these patients better. So the next one, like I said, I'm not going to go into the details of this, but you have to be mindful about this was the type 1 I just mentioned you. Now the type 2 is a person with a weak heart, which is going to get a weak kidney in future. Again, this is because, like we were saying, the main reason is filling problem. The filling pressure is going up, the renal vein pressure goes up, the filtration comes down. And this is the most interesting one I've seen these days, in which you have an acute kidney injury which impacts the heart. I think I'm trying to go fast so I won't discuss this too much. Alright, and this is the one we always see, standard of our patients, meaning having a kidney problem which we think is not serious, but it is. So 50% of all patients with stage 4 and stage 5 CKD have CVD. It's like every other patient already has it. You don't have to make a diagnosis of it. I'm sure it is there. And the mortality, and 40 to 50% of the mortality is a sudden death. That's the worst thing about these patients. They just suddenly die. Right. So why does it happen to these patients? So I'm just going to go through just with another clinical case. So this is a patient who is following up with our nephrologist. He said, okay, go and see the cardiologist also. And you're always wondering, how do we treat this patient? So you're trying to look at evidence to see, do I do an angiogram? Do I do this? It's such a challenge. So whenever my colleague nephrologist sends me a patient, I am wondering, oh my God. So this is a typical patient already on ECG. You can see there is ischemic changes. So it's for sure that he's got a heart problem also. This is the best thing I've seen. If you are diagnosed with CKD, you've just lost 25 years of your life. Meaning, if you are at 25 years of age, you are more like an 8-year-old. Your risk of a cardiac event is 10%. It's more like a 70 or 8-year-old person. So having a CKD at 25 makes you behave like a 75. Why does that happen? It's so amazing. So CKD is chronic kidney disease is diagnosed when you have a GFR less than 60 or albuminuria. Be careful about albuminuria. I think a lot of times we ignore that and we don't realize the patient is already in CKD. So this is just a classification of it. So we have high-risk groups. So even if you are, your eGFR is not too bad, but if you have proteinuria, that's enough. So etiology, of course, aging population. If I can just take a very interesting thing I realized was, after 25 years of age, our nephrons start withering away. Yeah, really. So after 25, our nephrons are going down and down and down. And if we were to live to 90, most of the time we will outlive our nephrons because we would have lost all our nephrons and we will land up in renal failure. And sometimes we are born with not enough amount of nephrons, then we will land up in renal failure even before 60, 70 years of age because we've run out of them. So it is very imperative that we try to preserve it. And diabetes and blood pressure are really common reasons. I think the main thing now I understand is our own therapeutic inertia in not trying to treat blood pressure and diabetes well and not be aware of renal injury. Because there are no markers for us to find out if our patient's kidney has been affected. Because, like heart, you have ECG, you have troponin, you have echo, all those things. For the kidney, nothing much. So I think these are the reasons why CKD is becoming so much more because it is very difficult to pick it up early. So the reasons are we have the traditional risk factors, but there are a lot of other things which are happening. I would kind of summarize it like this because the kidneys are organs which filter out a lot of waste, and when these wastes are not going out, they start accumulating in the system and they are affecting our blood vessels directly. We can call it our interleukins, we can call it also the tumor necrosis factors, all sorts of things. So all these things which should have been let out by the kidney is not going out, and this is having a bad influence on the heart. And not only that, there is excess amount of fluid in the system. This is just a slide which shows that. I'm not going to go down. So I just picked out the main 3 interesting ones which I found was very interesting to cause acceleration of the vascular disease. So we have our usual high blood pressure, diabetes and all those things, but these 3 ones I found it really interesting to see. One is, the lipid profile completely changes. You are now seeing patients in which there is low HDL, high triglyceride and kind of okay LDL. but still they are extremely, have a very high atherogenic potential. What you see is the HDL, we kind of think is a good protective cholesterol changes, because the HDL has the protein molecule and the lipid molecule. Now this gets modified by all the renal toxins, right? The proteome and lipidome they call it. They change so that this HDL is no longer protective. It is just as harmful as the LDL. And not only that, you remember HDL is a small guy, so he can get in anywhere. LDL is a low density, is larger, so he cannot get into the blood vessel wall. The HDL is, once it's modified, meaning it's armed now. It is armed in a bad way, and it can cause extensive atherosclerosis. So it's a modification of the lipids, which is caused by the renal failure, which is one reason. Another thing is vascular calcification, like Dr. Yaru was mentioning to you, and we are going to see more of it. And as a cardiologist, when you become older, you feel good. We don't have to treat with these guys anymore, because there is so much of renal failure happening, and renal failure produces so much of vascular calcification. Why? Because usually the middle layer has this muscles which are for contraction, relaxation. Now these guys modify. They become more like a secretory function, and they start producing calcium. So you have your blood vessels very stiff and thick, and that can of course cause atherosclerosis. It can cause vascular disease. But worse than that, I see, is what happens when you have a very stiff artery is you have a blood, when the pulse comes, there is something called the pulse wave velocity. The pulse wave comes and it goes, and it reflects back and comes back. Suppose you have a very stiff artery, it goes down and comes back very quickly. So you have these patients in which the systolic blood pressure is very high and the diastolic low. Imagine that. So the pulse wave is coming out of the heart, usually it just goes and it's very difficult for it to come back, because the blood vessels are nice and elastic, doesn't allow it to come back that much. But suppose you have a very quick, stiff artery, it just goes and comes quickly, and it causes the systolic blood pressure to go up and the afterload on the heart to go up. So these are the reasons why it is such a dangerous thing for the heart. And next is, of course, the inflammation we were talking about. I think it's just going to basically say, I felt it was like this: the kidneys are no longer excreting all these dangerous toxins, and it's producing inflammation. So when you come to therapy, so this is what I was talking about, my colleagues sending me these patients, and you wonder what to do with them. Yes, we know blood pressure we can treat. Of course, we have lost a lot of important drugs which we can use for these patients, because the creatinine is now high. And thankfully, there are some good anti-diabetic medications which are coming up. I don't think I'm going to talk too much about it, but it's very interesting. I think it's really giving us some some weapons to treat these patients. These are the SGLT2 and the GLP. We have very good criteria. We have really good areas to treat it. But one thing I really ponder a lot of times is we know these SGLT2s are very, very effective drugs. They always say we don't use it in a low EGFR. But they are not toxic like the AC inhibitors or ARBs or aldactone. They're not toxic to the kidney. They are not recommended in these clinical trials, because all these clinical trials were looking at their effect as in for treating diabetes. So if you have a very low GFR, the glucose doesn't get excreted. So it's not going to work as a good anti-diabetic. But I feel as a heart failure medication, as a renal failure medicine, you can still use it. And the Emperor Preserved is a good trial which has come out, and they are using it right up to less than 20. So we have to be, I think we can be brave here, because we are not looking at a drug like an AC inhibitor in which you can have hypotension or hyperkalemia. So yeah, like I started off, there is a clearly lot of we don't use many drugs for these patients, and we have a lot of gap in the understanding. And the therapy, so we just mentioned that high blood pressure, diabetes. Okay, now whenever you have, again I'm just quoting Dr. Yari, he was saying yes, you should look at treating them medically well. So when you come at medical treatment, what are our main drugs are statins and aspirin. This is what we all use, and these are what we found to be really effective. The problem is, once you get into renal failure, statins lose their effect. There are 3 trials which have done in really patients with renal failure. The SHARP, 4D and Aurora. None of them showed any benefit. So Why it's not showing any benefit is because our lipids have completely mutated to another type, so they're not going to listen to our statins anymore. So statins are not helping. And antiplatelets. Like I said, we use antiplatelets for our patients and we know it works. It reduces 15%. But you cannot use, I mean, it is unlikely to be helpful because lots of patients with CKD die not because of an acute MI or anything, they have a sudden cardiac death. And antiplatelets are not going to make any difference, and these persons have a high bleeding risk. Right, so the two of the main drugs we use in prevention, statins and aspirin, are questionable here. So this is an interesting, this is a very interesting trial that I picked up. Like we all talk about aspirin reducing things. Yes, it reduces chances of fatal MI. It reduces stroke, cardiovascular death. So meaning it's on the left side of the line, it means it's helpful, it's protection. But this means that there's something called confidence interval, meaning like, but this is crossing easily. Can you see that? When the line is more towards the left, you know that it is helpful, like this one. So this line is complete towards the left, so we know that it helps in myocardial infarction. But when you feel that the line is across the middle, that means the benefit is not so sure. So in stroke, it's not helping. In cardiovascular death, it's not helping. All-cause mortality, it's not helping. So it's only a benefit you get by treating patients on renal failure with aspirin is it prevents an acute heart attack, nothing else. And chance of bleeding, stroke, everything is high. So this is the same thing. I picked it up from another trial which shows the same thing. That it reduces MI, it reduces stroke, but not by, but then this line is all across the midline, so it's really not so effective. Maybe a slight, that mortality is kind of null, meaning it's on that line, but it definitely causes major bleeding. So a patient, like the patient we were talking about, who gets referred to you wonder what to do with him now, because antiplatelets are risky, we are not sure at all it works. Okay, now the ECG was showing STT changes. Should we do an angio? So that's the thing, because the guy is stable, he is not acute, he is just, maybe if you question, he might say that I've got some effort intolerance, but no angina. So, but he's got STT changes, so would you do an angiogram in this guy? So this is a big ischemia trial which came out a few years back, and you have the ischemia trial itself as a CKD wing, in which some 700 patients were having chronic kidney disease, and you looked and saw whether there's any benefit. None at all. So there was no difference between invasive and non-invasive treatment. But these are stable patients. Don't get the feeling that, no, we have stable ischemic patients and unstable ischemic patients. Let's not confuse the same. There are unstable patients in which you should do an angiogram, and it is very important. But these are stable patients. He has a stable coronary artery disease patient. I'm sure Dr. Manisha will be talking about it. So ischemia CKD again showed there is no advantage by revascularizing. Actually, these guys did bad because they had more strokes. Now, the next aspect of the ischemic heart, CKD patients is LVF. They come with a lot of LVFs, and the reason for LVF is the myocardial changes. I think for brevity of time, I'm just going to go quicker. One interesting aspect of their peculiarity is that there is developed a lot of fibrosis in the myocardium, and this fibrosis is between the cell and the blood vessels. So basically the myocardial cell is robbed about from the blood vessel. So they go into, initially they have good thick hearts, but over time they develop a left ventricular dysfunction. This is because the cells are going to be strangulated by this fibrosis process, because that sits right in between the capillaries and the cell. So treatment again, AC inhibitors and ARBs can be tried, but again they are only in the first 3 stages. Once you go down into the stage 4 and stage 5, no. But beta blockers, I think these are the guys to use. If you look at the clinical trials, the only drug which has shown me of any benefit is beta blockers in stage 4 and stage 5. Why? Because lots of deaths in stage 4 and stage 5 is due to sudden cardiac death, and beta blockers is the only one which can do something about it. So all the other trials, we have absolutely no evidence. And if somebody noted it, our patient actually had atrial fibrillation. So do we give them anticoagulants or not, and if so, which one? This is a point. We all have our trials which shows that you can use it up to 30. Below 30 is a problem. But I can tell you that the warfarin is really dangerous for these patients because it increases the calcification of the blood vessels, it can produce glomerular bleeding, and none of the trials have shown it to be a benefit. So I think once it's less than 30, you have to interact with your patient and see which is more important. And if they feel it's a fit and well patient with a high risk of a thromboembolism, you should give the NOACs and not the VKS. So VKS are very dangerous in CKD patients, and I think will be trials coming out in future. Dose adjusted NOACs will be coming. So this is a trial, this is from Jack, which is saying what to use. So when you have stage 4 and stage 5, there is no RCTs to compare. So you are supposed to discuss with the patient and see whether he would like to accept the risk of a bleeding with a NOAC. But NOAC, we do not use VKA. So what's the novel therapies which we have now for, it's not always such a gloomy picture. There are novel therapies coming, and the SGLT2 inhibitor like this editorial in NEJM, we have a formidable, we have a win against a very formidable foe, because heart failure with preserved ejection fraction we are all seeing, but we have very little to offer. Finally, we have some drugs which are happening, and these are again our SGLT2 inhibitors. So something called Emperor Preserved came out a couple of weeks back. I'm sure most of us would be aware of it, which showed creditable response in patients with heart failure with preserved ejection fraction, reducing hospitalization. Primary death wasn't so great, but I think if you look at the composite of heart failure admission and death, it was a winner. So that's a good molecule we have now in the treatment of heart failure with preserved ejection fraction. Yes, it can be used in non-diabetics also. And so this is how it stacks up against all the other big heart failure trials. See, compared to even with Paragon and HF, which we use this Entresto, this is much better. So Emperor Preserves outscores most of the heart failure trials we have. And another new molecule which has come out is the aldosterone inhibitor, mineralocorticoid receptor inhibitor. Because why it's interesting is, when you have a heart failure patient, you use your ACE inhibitors. What happens is when you suppress the angiotensin receptor, the aldosterone starts going up. So you need to block that level also, because you block this level, but the other guy is unblocked. So it's always recommended to use an MRA, and MRAs really help. But again, in kidney failure patients, we don't have much evidence till this guy came around. So this is another trial which is called the Fidelidone, which shows that finerenone is something like our eplerenone, but it is non-steroidal, much more safer, doesn't produce so much hyperkalemia. Again, shown to reduce CKD progression. So these are two very novel therapies which is making us excited in treating our patients. So I don't have to feel very upset when I get a CKD patient coming to me. But the interesting thing is, lots of deaths are due to acute sudden cardiac death, and we really have very little to offer. None of the trials on ICD, CRT have excluded these patients, so we really have very little evidence other than use beta blocker. Right, so CKD, 50% of the patients have heart failure or 50% have CAD. Treatment is tricky, but when you have to be mindful of using the appropriate therapy in these patients and not deny treatment. So I've tried to cover it quickly. If you have any questions, please let me know.
Thank you, Dr. Mahesh, for this extremely, exhaustive and very pathophysiologically orientated presentation.